on the NIH VBAC consensus guidelines, changed the recommendation for VBAC is a level A recommendation. The recommendation for VBAC after 2 cesarean sections that are candidates is level B, which is still some science, it's just not the best science. The recommendation for letting a woman with an unknown scar, as long as the history isn't significantly suggestive of a classical, is also level B evidence to be successful. But where they say that having a VBAC should be in a facility capable of emergency delivery, that's also level C evidence. So again, there's no evidence to support that that's the case. And if you take a risk of 1 in 200 as the standard quoted risk of VBAC rupture, and you also take the risk of about 1/10 of those, or 10% of those, are going to be catastrophic, then you end up with a risk of a catastrophic outcome in a VBAC of about 1 in 2,000. It's not likely. It is possible. It's tragic when it happens. But I will also say that in my experience as a home birth practitioner, the likelihood of a ruptured uterus at home is probably less than the ruptured uterus in the hospital. And that's simply because women are treated differently at home. They're able to move around, they're able to walk, they're not numb, they're able to eat, and they're able to sense things that maybe with an epidural laying flat in bed and being examined a lot, that may contribute to problems that don't occur at home. I have now done 30 VBACs at home over the last 4 years. I've had a 91 success rate in VBACs after 1 cesarean section. I've done 4 out of 4 VBAC after 2 C-sections and 3 out of 3 VBAC after 3 C-sections. I'm not saying that this is something that should be done by midwives. I'm just saying that a lot of people come to me in my small little practice because they have no other airplane to get on. So I think that taking away, just as it took breech away from midwives who knew how to do breech, but the OB residencies in the country are not teaching breech delivery to doctors anymore, so breech delivery is going to disappear. Even though we had qualified midwives who knew how to do breech delivery, taking VBAC or qualifying, you're not taking it away, but making patients, putting another obstacle to patients, which by our own admission wouldn't change the catastrophic outcome that's going to occur periodically, it doesn't make any sense to me as a practicing OBGYN.
Thank you. Karen, do you want to then Jen?
I just wonder, right on what you said about catastrophic outcome, the NIH actually pegged the risk of a baby dying from a uterine rupture at about 1 in 3,400 to about 1 in 7,000. The rate is about 2.8 to 6.2% of uterine ruptures will result in fetal demise. So when we back that out to what is my individual risk, it's about 1 in 3,400 to about 1 in 7,000. So it's pretty rare for there to be a baby that dies from a uterine rupture.
My name is Alex Rounds, and I'm here as a representative of CFAM, or California Families for Access to Midwives. I'm not used to talking in front of so many people, so I'm going to read. Thank you. All right, so we do not believe that the medical board needs to change current regulations or practices regarding VBAC. They've been working well for years. There's no evidence that seeking an OB consult will result in safer or better outcomes. We also believe that requiring an exam puts an unnecessary burden on mothers in rural areas, especially where no VBAC providers exist except for licensed midwives. These mothers face traveling or difficulties with traveling for consults or arranging consults online. That would impose both greater costs to them and without any evidence that it would increase their safety or their weakness.
I think that perhaps the discussion in this area should be directed towards what limits on number of VBACs or number of C-sections or types of incision. Should there be parameters around this, and if so, what will that look like, Ms. Sterling?
I'd just like to point out as we begin this part of the discussion that the regulation that's been in effect since 2005 doesn't specify any of those things. It doesn't talk about 1, 2, 6, or 20 prior C-sections. It only spells out how the informed consent is to be given and leaves the decision about whether or not that woman is an appropriate candidate for a home vaginal birth after cesarean between the woman and her midwife.
Can I say that I do believe it does not, that classic incisions are not included in what she just said.
Also,
You know, I wrote it and I remember saying, putting low transverse incision. No, it's not in there.
It's not there.
Okay.
And I'm not saying it has to be in there. I'm saying that when we put the proposed language forward, because right now, just to clarify it, we're in early stages. Eventually, there's going to be language that is drafted that will go before the Medical Board of California, and the members will vote whether that's the language that will be noticed for a 45-day public comment period. So I expect that we'll get a lot of comments, but I'm hoping that significant agreement can be made by the parties that are here so that we can have justification for all the items that are in there. Just like ACOG, I believe, will have to compromise on VBAC to some extent. They could push back and say, these VBACs are okay, but there needs to be some limitation, and what will that look like? So I want to put that out there because I don't want the regulations to be derailed, down the line at a later point, if we can reach a compromise on what really is necessary for patient safety. And if it's not necessary for patient safety, it not be in there. If it doesn't meet the language of the statute, and I have to interpret the language that likely was put in there for a reason, if we can't justify limitations that they're in there because they are likely to affect the pregnancy, they're not going to get through. And so perhaps we need to move on to other line items, but this is something that you should assume that VBACs will be allowed without a physician consult. And does there need to be parameters around that?
I think what I and many of my colleagues, like Rachel Hansen, I'm a licensed midwife here in Sacramento.
Rachel who?
Rachel Hansen. Keep coming back to is that we do and want to continue to refer to obstetricians or higher level medical practitioners whenever there is a benefit to our clients of doing so. In cases where it's simply a matter of an informed consent, I think that referring, I think informed consent is something that licensed midwives do probably better than anyone else. And we, having spoken to dozens of women whose informed consent for repeat cesarean did not include any thorough discussion of the risks of cesarean, which are higher than the risks of vaginal birth. I think that that's something sometimes that's lacking in those we might refer to in the obstetric community. However, with all these, we have to ask the question of what's the benefit? How does it help the client? And if it's clear to us that ACOG is opposed to VBAC at home, and is opposed, in fact, to home birth, is their stated opinion, then it's very difficult to see how with many of these issues, VBAC and other issues, that there's actually a benefit to the client of going and having to have a consultation with an obstetrician that is much more likely to present barriers to the birth that they might reasonably choose for themselves than it is to improve their outcome.
Jen, and then Ms.
Well, I'd like to talk a little bit about those risks, especially when we're talking about higher order VBACs. So when you have a woman who has 2 prior cesareans, it's very difficult for a woman to have a VBAC with 2 prior cesareans in the state of California. It's difficult enough with 1, but with 2, that option is almost entirely disappeared. And so each time a woman has a cesarean, her risk of placenta accreta, where the placenta abnormally attaches to the uterine wall, increases. In fact, the risk of placenta accreta after only 2 cesareans is similar to the risk of uterine rupture after 1 cesarean, yet women are rarely counseled in this fashion and are not informed on how the rates of accreta-related and uterine rupture-related mortality and morbidity compare. So if I can just go over how those risks compare a little bit. So we're talking about avoiding surgery versus having to have that second or third or fourth C-section. So 54% of women with accreta will require a blood transfusion as opposed to 12% of uterine rupture moms, and I can give you all the citations for this for these statistics. 14% of accreta moms will require ventilation as opposed to 3% of uterine rupture moms. 20% of women with accreta will need a cesarean hysterectomy, which comes with its own host of comorbidities, whereas the rate of cesarean hysterectomy is 6% among uterine rupture moms. 43% of accreta babies will weigh less than 2,500 grams, which is 5.5 pounds, upon delivery due to the high rate of preterm delivery required for those women with accreta. And this will have lifelong implications for these children. 5.8% of the accreta babies will die within 28 days of delivery, which is similar to the rate of uterine rupture-related perinatal mortality. And per ACOG, accreta is associated with an up to 7% maternal mortality rate, and yet with the NIH looked at VBAC maternal mortality. Of the 8 studies they reviewed, there was not one reported case of a uterine rupture-related maternal mortality. And so I actually did a little poll over the weekend of women who had accreta or women who were pregnant after cesarean, and I had 226 women respond, and 93% of women who were ultimately diagnosed with accreta, as well as 93% of women who were pregnant after cesarean, said that their provider never informed them on the risk of accreta when they were pregnant after 1, 2, or 3 cesareans. And 59% of the women who had accreta first learned the word when they were diagnosed. So the way that women are counseled about their VBAC options and counseled about the risks related to VBAC is very different than how they're counseled about the risks of C-section. One woman said, even after my 4th or 5th C-section, my doctor never told me anything about accreta. I had never even heard of it, and I honestly wondered if my doctor even knew much or anything about it. I was told I was not a candidate for VBAC during my 2nd pregnancy due to the risk of uterine rupture because I was told I had a thin uterus. In my 3rd pregnancy, I had procreta, and that's when the placenta goes through the uterine wall and adheres to other abdominal structures, most commonly the bladder. Another woman was told 5 cesareans, and I was told nothing, only warned about uterine rupture. I mean, I have probably about 175 comments that sound just like this. Women who were never informed. So I just want to make clear when we're talking about risks and benefits, there are uncommon, those serious complications that can come from VBAC or repeat cesarean. And we have to keep that in the back of our minds when we're talking about women being able to avoid surgery and attain a vaginal birth. And for some women, having access to home birth means having access to a vaginal birth, period. Because if they go into a hospital, especially with higher order VBACs, they will end up with a repeat cesarean unless they have access to the few special practitioners that attend higher order VBACs in the hospital.
I just want to reiterate what Rachel is saying and what Jen is saying, which is as we craft these regulations, it is really, really important that we recognize that the job of the medical board is to protect public safety. And so if we're putting something in regulation that doesn't increase a woman's safety or positively impact her course of care by asking that she have a referral to a physician, we better think about why we're putting that in the regulation. There should only be things there that are really going to assist women in having healthier outcomes, not put barriers in the way of their care. And particularly, I think that when we look at some of the items on the list that are history of or previous, we need to really question how having a physician referral for that condition is going to change the course of their care to the positive.
I'd like to mention something that I think for ACOG's standpoint, we haven't talked about, which is that what makes VBAC and uterine rupture such a big deal has to do with litigation, that the risk relative to VBAC is different than the risk versus all of these other things, including the accreta, cord prolapse, other things. There's the assumption in the medical malpractice world that somehow or another the doctor should have prevented that by simply doing a C-section, and if something goes wrong, then they're screwed. But I think from the standpoint of midwives that we're looking, and mothers as well, that we're looking at this risk is not that much different than many others. There are other legitimate risks in providing care in an out-of-hospital setting. We don't see them to be so sharply defined or contrasted.